Welcome to This Explainer. Today, we're diving into what I think is a totally fascinating medical mystery. We're talking about the hidden, actually entirely curable side of high blood pressure. Seriously, we're going to approach this exactly like medical detectives trying to solve a really complex case. High blood pressure is something we hear about all the time, right? It's often treated like this inevitable fact of getting older. But there is a specific, hidden variation of it that functions completely differently from all the rest. And finding it, well, that can change a person's life forever. Now, to understand the true stakes of this mystery, just look at this massive number. Over 30% of Nigerian adults suffer from hypertension. That is a staggering public health burden, and honestly, it mirrors similar trends globally. Millions upon millions of people are just walking around right now with elevated pressure in their blood vessels. And for the vast majority of these individuals, this high blood pressure is treated as a lifelong condition. It's something they just have to relentlessly manage, with daily medication, diet changes, and constant monitoring. But what if it actually didn't have to be? Well, here is our first major clue. Tucked right within that massive population is a hidden subset. About 5 to 10% of those cases are what we call secondary hypertension. Now, at first glance, that percentage might seem kind of small, right? But mathematically, that represents a massive number of actual human beings. And very often, these are younger patients who are living with a condition that isn't just standard everyday hypertension. They actually have something else entirely going on right beneath the surface. And here's why identifying those specific patients is an absolute game changer. If we can find the underlying cause of their secondary hypertension, their high blood pressure is potentially 100% curable. Just let that sink in for a second. 100%. Instead of a literal lifetime of taking pills, constantly adjusting dosages, and worrying about severe cardiovascular risks, these specific patients have the possibility of a complete, permanent cure. That is exactly why it's so absolutely crucial that we know what to look for. So to solve this case, we first need to know what we're looking for. For the vast majority of people, they have what's known as primary hypertension. That just means they have elevated blood pressure with no single identifiable cause. It's basically just how their body is functioning, usually a mix of genetics, age, maybe lifestyle. But secondary hypertension, that is an entirely different beast. It has a specific, identifiable, and most importantly, reversible culprit hiding somewhere in the body. The high blood pressure is really just a blaring alarm. It's a symptom of another problem, not the problem itself. The crucial part then is figuring out exactly where that underlying problem is hiding out. Think of the body's blood pressure like a highly complex plumbing system. It's controlled primarily by two main regulators. First, you've got the renal system, which acts as the fluid manager. And then you have the endocrine system, which is kind of like the main control center, sending out hormonal signals. When something goes wrong in either of these two systems, the pressure in the pipes absolutely skyrockets and it stays dangerously high. Now, the real ringleader of this plumbing system is a four-step chain reaction known as the RAS cascade. It acts a lot like falling dominoes. First, the kidneys release an enzyme called renin. That triggers the formation of angiotensin II in the blood. This then signals the adrenal glands to pump out a hormone called aldosterone. And finally, that aldosterone hoards sodium and forces your blood vessels to severely constrict. The result? A massive blood pressure spike. Normally, this system is actually meant to keep you alive and maintain balance. Like, if you get severely dehydrated, the RAS kicks in to maintain your blood pressure so you literally don't pass out. But when this exact hormonal cascade gets stuck in the on position, well, that's when it becomes our main suspect. The blood pressure shoots up, it stays up, and it completely resists standard treatments, all because the body's internal thermostat is fundamentally broken and constantly calling for more pressure. So how exactly do we catch our suspect? Well, we pull out our magnifying glass, which in this case is our biochemical toolkit. By looking at some pretty simple blood and urine readouts, we can essentially interrogate the body to tell us which organ is malfunctioning. Low potassium hints at a deep hormonal imbalance. High creatinine points to struggling kidneys. And protein in a urinalysis, that leads us straight to a physical, structural kidney defect. Okay, so if our biochemical clues point to the kidneys, we have to look a bit closer to differentiate between two distinct renal culprits. The first is renal parenchymal disease, which is actual physical chronic damage to the kidney tissue itself. But the second culprit is renovascular hypertension, and that is a literal blockage in the kidney's blood supply. Unlike the chronic tissue damage, this one often presents with a severe, sudden onset of high blood pressure and heavily elevated renin levels, basically as the kidney desperately cries out for more blood flow. You know what's really fascinating and honestly slightly terrifying about kidney tissue damage? It's this vicious cycle. It can actually be both a cause and a consequence of high blood pressure. High pressure batters and damages those delicate filters in the kidneys, and then those damaged kidneys release panic signals that drive the blood pressure even higher. Breaking this loop early on with our detective work is absolutely critical, long before the damage becomes permanent. But what if the kidneys are perfectly healthy and our clues lead us somewhere else? Well, we look just above them, right to the adrenal glands. These small triangular glands sit directly on top of the kidneys, and frankly, they can sometimes just go rogue. They can start overproducing a mineralocorticoid hormone called aldosterone. When they indiscriminately pump out too much aldosterone, they essentially command the body to hoard sodium and dump potassium, completely hijacking your normal blood pressure controls. This specific rogue behavior is called primary aldosteronism, and it's actually the most common endocrine cause of secondary hypertension. And because it involves this specific hormone, it leaves behind some very unique biochemical footprints. As detectives, we're looking for resistant hypertension that completely ignores standard drugs. We're also looking for unexpected muscle weakness or cramps. This happens because the patient's potassium levels spontaneously plummet to really dangerous levels, a condition known as hypokalemia. All right, let's take everything we've just learned and put our detective skills to work on a real case, directly from our source material. We have a young 32-year-old woman presenting with dangerously high blood pressure of 170 over 110. Now, she is incredibly young to be experiencing this, and she's already taking 3 different antihypertensive medications. And guess what? They are completely failing her. On top of that, she comes into the clinic complaining of mysterious muscle weakness and severe cramps. Seeing her young age and that stubbornly resistant hypertension, we immediately break out our biochemical toolkit. And boom, there it is, the smoking gun. Her serum potassium is sitting at a dangerously low 2.8, alongside elevated bicarbonate, which indicates metabolic alkalosis. Now, these aren't just random bad lab values. This is the exact undeniable fingerprint of mineralocorticoid excess. Her body is literally dumping potassium while intensely hoarding sodium. To absolutely confirm this excess, we order a specific screening test. It's called the aldosterone-renin ratio, or ARR for short. Basically, we want to see if these two hormones are communicating and balancing out the way they're supposed to. While her results come back markedly elevated, well over 30. This means her adrenal glands have officially gone rogue, pumping out massive amounts of aldosterone completely independent of any signals from the kidneys. The feedback loop is totally broken. Just to be absolutely certain, a saline infusion test is performed. See, if her body were functioning normally, a rush of saline would instantly suppress her aldosterone production. But it doesn't. Her body completely fails to suppress it. With that final puzzle piece squarely in place, we can confidently close the case, the diagnosis, primary hyperaldosteronism, also known as Conn syndrome. By locating a tiny, benign adrenal tumor, we have found a completely curable cause for her severe hypertension. Which leaves us with this final, really vital thought to take away from this explainer today. If up to 10% of people suffering from hypertension, we're talking millions of individuals globally, are living with a condition that could be permanently cured with one precise diagnosis, are we looking closely enough at the biochemical clues? We have the toolkit, guys. We just need to use it. Thank you so much for joining me on this deep dive, and remember, always keep questioning the clues right in front of you.